The eye sees, perceives, looks, understands. But the eye also knows how to smile, laugh, cry. It's by studying the eye, its richness and complexities, that Santen has continued to develop and sell for the past 120 years innovative treatments to preserve this precious organ. In today's world dominated by technology, the eye has never been so essential. At Santen, we are committed every day to improving the quality of a patient's sight, thus improving their quality of life. Thanks to ever more effective solutions for treating ophthalmic conditions, we ensure a brighter future in ophthalmology. Born in Japan, we develop our expertise for the benefit of patients and physicians around the world. Our philosophy, our clear vision, exploring the secrets and mechanisms of nature in order to contribute to people's health. Santen, a clear vision for life.
Good evening and welcome to the last part of the three-part series of lectures on the review of cornea and external eye diseases in the age of teleophthalmology by Dr. Ruben Siong. For our welcome remarks, may I call on the President of the Philippine Cornea Society, Dr. Reynaldo Santos. Dr. Santos?
Yeah, thank you, Jen. Good evening to everyone again. On behalf of the Philippine Cornea Society, I'd like to welcome you to the last leg of a three-part lecture series on the review of cornea and external disease in the age of teleophthalmology. I think we have pretty much covered everything about external eye, coming from the lids to the conjunctiva, and now we're zeroing in on the cornea. And we will have no less than our immediate past president of the Philippine Cornea Society to deliver this last part of his three-part series of lectures. So without much ado, I'd like to give the floor to Ruben. Ruben, please.
Thank you very much, Ray. Okay, are we on?
Yes, we are.
You see the slide?
Yes, we see the first part.
So good evening, everybody. So it's nice to be back. And this will be the third part of the series of lectures on the review of corneal and external eye diseases. Okay, so previously we talked about blepharitis on the lids, MGD or jawlum dry eye, and herpes zoster. Then the part two was on infectious conjunctivitis, allergic conjunctivitis, ECGs, pinguecular nodular scleritis, and today will be the part three. We'll talk about infectious keratitis, frectenulosis, marginal keratitis, interstitial keratitis, and end with paddy keratitis. Okay, so the cornea. So the most common problem, of course, there are a lot of conditions that is related to the cornea. There are congenital problems, okay, there are acquired problems, there are trauma to the cornea, but we will not be able to cover the entire spectrum of corneal diseases. Okay, so we'll just talk on a few, basically concentrate ourselves on the infectious ones, especially on corneal ulcers, which is a problem that can cause devastating effect if it's not treated early enough or treated properly. So this usually is the, if you're usually a resident, will always refer a patient because they will say that, sir, corneal ulcer. Okay, so they all look the same. Okay, so what should you do? Because all you can see is an red eye with a corneal opacity. And nowadays, if you're doing teleophthalmology and there's a patient who develop a corneal ulcer, and they don't have a slit lamp or a good camera to take the findings on the cornea, you just end up with a cell phone photo with a red eye, with tearing, and with a corneal opacity. So how are you now be able to diagnose, not short of doing a slit lamp? and doing scrapings and doing all the other ancillary tests. So it's very important when you're faced with a patient with corneal ulcer to make an etiologic diagnosis. It's not enough to just say patient has a corneal ulcer, a central microbial ulcer, or infectious keratitis. You have to make an etiologic diagnosis. And you can do that based on the history, slit lamp findings, and microbiologic studies. For now, when you do a teleconsult, maybe you just have your history to help you come up, at least narrow down the different types of eye problems, that the etiologies that can cause an infectious keratitis. So first, as a rule, the location of the problem of the lesion. No? Where is the ulcer located? Central corneal ulcers are infectious, while marginal ulcers are inflammatory in etiology. Okay, so as a rule of thumb, kung nasa gitna, okay, para central, it doesn't have to be right at the center. You know, it can be within the central 8 millimeter zone, and you consider that as a central corneal ulcer. And those lesions there, those ulcers there, are usually infectious in origin. Okay, while those at the far periphery, the margins of the cornea, those are usually inflammatory or immune-mediated in etiology. Of course, there are exceptions. Now, one of those, of course, mentioned that before is your gonococcal conjunctivitis, no? Which usually the ulceration starts at the periphery but you have other very obvious findings, no, in those patients. So it will not be hard to make a diagnosis of gonococcal corneal ulcer in those cases. So this is an example. No? So if on the left side, the central is how you have a lesion right at the center. No? So that's a central microbial keratitis. Okay, that is almost always sure that you're dealing with the microorganism causing that problem. And on the right side, you have your peripheral ulcerative keratitis. No? You have a furrow. Okay, you have a marginal ulcer, or what we call the PUK. Then it could be autoimmune. Usually, it could be rheumatoid arthritis. It could be Murren's, no, and the long list of autoimmune diseases that could cause peripheral marginal melt of the cornea. Okay, so patients comes in, show you a picture. You saw on the photo they sent by maybe by Viber or by Messenger. Okay, a red eye, and then you saw a lesion, a white opacity at the center, with or without hypopyon. At least you have a lesion at the center, an opacity. Okay, then if you see that, then you can tell yourself this is most probably infectious. So if it's infectious, what are you going to think about? Okay, hindi naman ganun kadami, no? It's okay. You're not talking about hundreds of organisms, no. You just have 4 big groups. You have your viral, your bacterial, your fungal, and your parasitic. Okay, viral, your herpes simplex, varicella zoster, adenovirus, Epstein-Barr virus, pox virus. Okay, so viral like herpes simplex, they will not show you a very dense infiltration. No? So you may not actually see a dendrite based on the cell phone photo they will send. So if you don't, then if they see an eye with an opacity, with a white opacity center, you actually just have 2 things to think about. Is it bacterial or is fungal? So if it's bacterial, then you think is it staph? Is it strep? Is it Pseudomonas? It is Moraxella. Okay, and based on the results of the Philippine General Hospital, the ED Clinic, based on Dr. Valentin study and later studies, the most common still Streptococcus, Pseudomonas, and Moraxella. Those are the top 3 organisms that you would think about if you are thinking about bacterial. Then you have your fungal. Okay, then if it's fungal, basically you think of Aspergillus, Fusarium. Okay, and not so common will be Candida. But again, 99% of the time, it will be Aspergillus and Fusarium. Canthamoeba, not that common. Okay, so you don't put that in the first of your list. Okay, patients comes in, red eye with a corneal opacity at the center. Okay, it's acute in onset. Okay, there's blurring of vision, there's foreign body sensation, there's pain. Okay, So probably it's bacterial or fungal. If it's bacteria, just three things: Strep, Pseudomonas, Moraxella. Fungal is basically a toss-up between Aspergillus and Fusarium. So yun lang muna ang isipin nyo. No? Those will be your very first impression as far as etiology is concerned. Of course, now you'd have to talk to the patient. Okay, so you ask the history. So at least in the back of your mind, you're narrowing it down. No? You already have your top choices, and then those not least other etiologies not way up in your list. If it's herpes zoster, usually the history is subacute. Okay, patient have the red eye today. I don't think patient will consult you today if it's herpes simplex. No, it takes a while. There's a red eye. Okay, there's some discomfort. It lasts for a few days. Okay, and there's not much pain because herpes simplex, it affects the nerve. Okay, there is hyposthesia. There is not, if it's at the periphery, they will not bother them because there will be no blurring of vision. Okay, so and then if you're thinking about herpes simplex, there's only one question that you really have to ask. Okay, did you have this exact same problem before? Okay, if there is a previous history of exactly the same problem, okay, then that narrows it down to herpes simplex. And the picture they sent you, you have a red eye, maybe a little, there's no discharge, there's just mild lid swelling, there may be photophobia, okay, but you don't see a dense infiltrate, no? Then the eye is not in pain. The eye is open, no? They are not coming to you with they will not send you a picture that with the eyes all shut and teary and or in pain. Okay, so subacute, no pain, maybe some discomfort, a little irritation or foreign body sensation with redness. Okay, in a previous history, then that is very compatible with herpes simplex virus infection. Bacteria is acute. Okay, can have a trauma today, usually sort of associated with trauma, or you wear your contact lens today, you wear it to sleep, the next day the eye's red and there's pain. Okay, it's that fast. Okay, there it's acute, it's red eye. Okay, it's usually located at the center, over the pupillary area. That's why the decrease in vision. Trauma is very important. Okay, it's unlike herpes simplex, wherein you don't need trauma to get it because it's already it's in your system. The bacteria doesn't just grow there de novo. Okay, either it has to be brought there, or there should be a breakdown of the surface epithelium for the bacteria, and then your normal flora there to attach to that denuded area. Okay, then cause an infection. Okay, so something has to happen first. So trauma, usually an abrasion or contact lens use. Okay, now the contact lens may carry the Pseudomonas. Okay, it can carry the Pseudomonas, and because if it's not used properly, there is microabrasion, and then the Pseudomonas can now gain a foothold on the cornea itself and replicate and cause an infection. Or an eye with a previous problem. Patients with recurrent corneal erosion, patients with the suture left behind, patients who have had LASIK before, patients who had bullous keratopathy, corneal decompensation, patients with very severe dry eye, okay, let's say in Stevens-Johnson syndrome, graft versus host disease, or in severe Sjogren syndrome. There should be something else. No? So it's a sick eye, okay, or a blind eye, okay, with a decompensated cornea, okay. So again, bacterial infectious keratitis will not just develop de novo. Okay, the eye has to be weak. There should be trauma, or there should be associated with the contact lens. Okay, same as fungal. Okay, but the history is a bit different. Okay, if bacteria is quite acute, okay, problem, there is the redness in 1 or 2 days, patient would already be seeking consult. In fungal, it's smoldering. Okay, they might have trauma today, but they won't really have much symptoms until a few days or after a week later. So if the patients will see you after a week, okay, or will consult you after a week, then maybe it's fungal. Okay, and then there should be there's something has to bring the fungus onto the corneal surface. Okay, it has the cornea epithelium has to break down again for the fungal fungi to gain a foothold and cause an infection. So very common organic matter. You all know that, no, vegetable matter. Patient's a farmer. Okay, nowadays insect. No, a lot of motorcycle people riding motorcycles now. Okay, and then they've got insects into the eye, probably not so much now in the city, but in the provinces, okay, when there are a lot of trees and vegetation, no, okay, there are a lot of insects in the on the road, no, so this can inadvertently get into their eye, no, if they do not have a shield on or the helmet on or with the visor down, okay, and they can get hit. Have insects hit the cornea and again bring fungal elements, no, into the cornea. Okay, or a lot of times, no, we have patients with no known trauma, no, parang wala, no, no matter what we ask, every little bit we dig, wala rin, no, pero kung wala, tapos it's chronic, okay, it's smoldering, okay, then maybe then it could be fungal, no? Because another way of looking at another theory is because again they might be sleeping, okay, or they have fungal spores are everywhere, okay. They could during a sleep but it might have accidentally went into the eye. They rub their eyes when they're sleeping, and then that can be the start of a problem, okay. And then lastly will be acanthamoeba, very actually rare, okay, where we only see one or no cases in a year. So you don't really put it way up in your list. Usually there is exposure to water, okay? So acanthamoeba, the organism is found in water, okay? They thrive and live in water, so there should be exposure to water. Trauma, then they wash with water, then you have a course that is it starts slow, and then there will be severe pain, okay? The pain is sometimes disproportional to the findings, okay. But again, there is exposure to water. You might think about acanthamoeba, okay. If it's contact lens usually it's contaminated with non-sterile water, then that can bring acanthamoeba to the eye. Okay? So those are the important things or important information that you should get from the history. And with that, you can narrow down, okay, as to the etiology of the corneal ulcer. Ideally, of course, no, it's a rule. Now, when you have a corneal ulcer, you really have to do a slit lamp examination because it's the only way that you'll be able to see all the details. Okay, and maybe somehow, if you're able to get hold, the patient's able to get a slit lamp photo, well and good. Or finally, of course, I would advise that any patient with infectious keratitis, especially central, you should ask for a face-to-face consult. Okay, it's a must. Okay, you cannot do away with a slit lamp. Okay, so the first part in the history. Okay, then if you think it is Pseudomonas or if it's fungal, then really they have to come in. Okay, so in the slit lamp, you have to look for these lesions. No? In the herpes simplex, you see the classic dendrites. When it's a bit older now, when they have steroids, then they will develop what we call their geographic, okay, or amoeboid ulcers. Again, very minimal infiltrates. You may see previous scars, okay, what we call the footprints that will tell you there are previous attacks of the problem. Okay, there might be KPs, there might be hypopyon, but if it's purely epithelial, you will not find KPs or hypopyon, only in your keratouveitis. Bacterial, dense infiltrates, okay, usually with hypopyon. Now, you have to check the borders of the ulcer. If it's present, it's very, very helpful, okay? Now, if you see brush-like border, again, it's acute in onset, there is contact lens abuse, okay, or misuse, then you're almost 99% sure it's Pseudomonas. If it's distinct, then there's trauma, foreign body to the eye, okay, then most probably it's the borders of the ulcer is distinct. It's probably strep, staph, okay, or your moraxella. Now, if the infiltrate is advancing means one area is healing and one other area is progressing. That's why they call it advancing. Okay, advancing doesn't apply. All of them will be advancing. Now, if you don't treat them, it will become bigger. Okay, but we don't use the word advancing for those. No? Those are just progressing. Okay, those ulcers progress. But if you say advancing, one part is healing, the other part is active, okay, and getting worse, then you call that an advancing border. Okay, we'll have some pictures. So, of course, your dendrite, you stain with fluorescein, you stain with rose bengal, and you see this branching pattern, okay, with a terminal bulb. No? The tip there should be a blunt tip, okay? The end should be blunt. Okay, you have a terminal bulb because you have to differentiate this from your pseudodendrite. A corneal abrasion, it heals, then they will always form a epithelial healing line, no? That you might mistake for a dendrite, okay? But if there is no bulb, if it's no terminal bulbs, then most probably it's not, okay? And don't forget, now you always have to check for corneal sensation, okay? More often, okay, and not, no, the corneal sensation will be less than normal, okay? So now I have geographic ulcer. Geographic ulcer, amoeboid ulcers are just dendritic ulcer that has progressed, okay? Lumaki lang. Una, pag, let's say, patient is immunocompromised or patient was given steroid, okay, then it will broaden. The dendrite will broaden, and they will have this amoeboid geographic appearance, okay? Here you see previous scars, no? Okay, so you have a large amoeboid ulcer there, and you see this scars from previous attacks, no? Again, those are highly suggestive of a herpes simplex. Okay, there's other pictures, no, of a scars. No? So this is what we call the footprint. Here you have a small dendrite that has healed. Okay, so you see that. That's a footprint. Mayroon pa sa ibang footprint dyan. Here also, no, you see this almost amoeboid shape, okay, of a scar. Again, that is also a footprint or a sign of a previous herpes simplex epithelial keratitis. Okay. Now, for bacterial CMK, this is an example of what we call a distinct border. Okay, so it's a central ulcer with very distinct border. So you have dense infiltrates, you have a breakdown of the overlying epithelium. This would stain with fluorescein. There's a minimal hypopyon and there's redness. Okay, and then there's a history of trauma, then most probably strep pneumo. This is advancing. Okay, so this is the whole ulcer. This is the previous. It started here. Okay, this has healed. Okay, somehow this has resolved. It has become a scar, and now this part is advancing. Okay, so this is still active. So put them side by side. This is a healed ulcer, and this is an active ulcer. Okay, this is dry with a grayish white appearance, and this is wet. Okay, with a creamy appearance. No, and then you see lots of infiltrates and DM folds and pressure hypopyon. So this is suggestive of your strep pneumo. Brush-like borders. Here you are, okay? Brush-like. And pseudomonas, don't forget, you have a lot of discharge, of this mucoid discharge, okay? Because of the collagenase action of they also form of the pseudomonas, and they form a lot. They are mucus forming, and that's why you get a lot of this discharge. So corneal ulcer, contact lens wearer, brush-like border, a lot of discharge, rapidly progressing, okay? Then this is pseudomonas. Ito mga less 5 days, no? Okay, and this one is around 3 days, no? They really progress very, very fast. So you see here also your brush-like border. Okay, these are brush-like, not scallop. Okay, brush-like borders. This is moraxella. Usually, it cannot be differentiated from strep. Okay, so also give you a distinct borders, very, very similar to strep. If you see an angular blepharitis in these cases, then most probably it's moraxella. Okay, but if lids are normal, the angles of the lids are normal, then it's very hard to tell. Okay, so it's a toss-up between moraxella and strep. Okay, these are also other cases of moraxella. Again, nothing very distinctive, okay, that will tell you that it's moraxella unless you have an angular blepharitis. This is nocardia, again, not a common. Again, this one will give the scallop edge of an ulcer. Okay, this is the growth of nocardia, okay, on culture. A typical mycobacteria or non-tuberculous mycobacteria is also a cause of bacterial keratitis, but a lot of times it's due to a wound. It's related to a stromal abscess, okay, from a corneal wound. No? So this is a post-phaco wound here. You see the stromal abscess, and this is much more severe now. Okay, with a very high, with almost half of the anterior chamber filled with hypopyon, and you see this stromal abscess, okay, in the entire thickness of the cornea. Again, but they do not, again, they will have, usually there's a history of previous eye surgery. Okay, so for fungal, okay, you also see infiltrates. You can see sticky hypopyon. It can be solitary or multiple lesions. Here you look for the feathery borders. You look for the epithelial plaque. You might see immune ring and scleritis in the severe cases. In acanthamoeba, it starts out only as punctate epithelial keratitis, so early findings. They're just like little punctate staining. Then they will form a line, okay, you call a pseudodendritic keratitis, but the more advanced one will develop a ring infiltrate. Very, very rare that you will see parietal perineuritis, no? In only less than 10% of cases, okay, you see central stromal infiltrates. You also see scleritis in advanced cases of acanthamoeba keratitis. So in fungal, okay, this is an early fungal, very superficial. Okay, the eye is not even that red. Okay, but you already see this this feathery. Okay, see that? It's like you have your fungus growing on your plate, no? Okay, or on your piece of bread. Okay, so this is this. You can see the actual branching of the colonies on the surface of the eye. Okay, here a more advanced one with dense infiltrate, but you also see this irregular. Okay, this irregular border. Okay, and then with the history that should be consistent with the fungal infection. These are two lesions here. Okay, this is one here, and this is another here. Okay, so you see this irregular borders, no? Because that's the nature of the filamentous fungi. No? That's how they will spread out. No? Okay, that's how they grow. Okay, even on your culture media, that's how they grow from the center and they grow outward. Okay, plaques. No? So if you see these epithelial plaques, no, these two are very far advanced. No? You have a large plaque here, okay, and you have a large plaque here, and it's not marginal it's perforated at the periphery. So these are, if you see this, no, almost always, no, it is related to your fungal keratitis. Sticky hypopyon, no, have the large, the hypopyon usually do not level. We call that sticky. Okay, it's sort of tent up. Okay, it's stuck to the endothelial side of the ulcer itself. Now you call that sticky hypopyon. But here the infiltrates, and you see the irregular borders of the ulcer. Okay? It's fungal. Immune ring. Okay, so this is not the ulcer itself. This is the ulcer at the center. These are the dense infiltrate with thinning. Okay, this is beginning the cementocele here. Okay, here, so this is irregular. Now here you see very distinct. People might mistake this. You might mistake this as the border of the ulcer, but no, this is just your immune ring that has formed around the nidus of the infection. Okay, so this is an immune ring. You also see that in acanthamoeba. Sometimes we also see that in Pseudomonas. Severe scleritis. Now this is far advanced now. Okay, so you see this scleritis. Okay, it's part of the presentation. Pigmentation, no? The sclera, no? Very not common, but sometimes once in a while you'll see an ulceration. Okay, then you see this brownish pigment or black pigments on the surface. Okay, this is your pigmented fungi, no? Your dematiaceous fungi. No? So you grow them on the subrods. No, you see exactly the same pigmentation on the plate. Okay, similar to that on the eye, on the surface of the eye. Candida, okay, not common. Okay, so it can happen. So you have to put that at the back of your mind. It will also give you indistinct borders. Okay, very slow growing. You know, slower even than your filamentous fungi. Okay. Now some more pictures on acanthamoeba. So this is the early appearance of acanthamoeba. Okay, almost very subtle, no? Just punctate keratitis. Okay, nothing very obvious. Okay, then here you see the pseudodendrite. So a lot of times these patients are treated first as herpes simplex, no? As herpes simplex epithelial keratitis, but they're not, no? Why? Because they're in pain. If you check the cornea, there is no loss of sensation, okay, and there's no previous attack. and there's some signs of previous scar, okay, and then there is exposure to water, okay, and if you have all that, then maybe it's a amoeba. So here is a ring infiltrate, okay, you see this ring infiltrate that forms, no? There's a ring infiltrate here, and this is the immune ring, okay, ito yung ulcer mismo, this is the ring infiltrate, this is the immune ring there. I'm not seeing, okay, ring infiltrate with scleritis. See that? Very violaceous sclera. Okay, so the sclera now is involved. Okay, so stroma infiltrates, no? Okay, eye injection. Okay, and then you see the breakdown of the epithelium, and this infiltrates in the stroma. Okay, so those are the important slit lamp findings, no, that you have to look for. That will give you a clue. So history plus a slit lamp examination, 90% of the time you'll be able to get the etiologic diagnosis. Okay, so you really don't have to go through the test. Herpes simplex, we hardly do anything. We don't even do PCR, okay, or even do any microbiologic test. Bacteria, yes, you can do it's possible if the lesion is big enough. Then if there's enough specimen, then you do a gram stain, you get specimen, at least culture on blood agar plate. Okay. If you're fungal, you can do even a KOH, or GIMSA. If you don't have GIMSA, just do a KOH and culture them on subrods. If you don't have subrods, you'll also grow on blood agar plate. Just put them in room temperature, okay, and they will grow. Because in bacteria, but they have to incubate this in the oven. Okay. In amoeba, a lot of times you're not able to get this. Where will you get calcium white? You don't know. You can sometimes use GIMSA and look for the cysts. Okay, and if you don't have a good lab, they don't even be able. You won't be able to do a non-nutrient agar E. coli overlay. Okay, so usually you end up just based on the history and based on your clinical findings. You need to make this in order to make the etiologic diagnosis. Okay. So again, the test, if ever, the minimum gram stain, KOH, culture and blood agar plate. Okay, at the very minimum. Okay, because that might prove helpful later on in case that you're dealing with a typical type of bacteria, or you're dealing with a pseudomonas that is resistant, to your moxifloxacin. Then you might have to you will know that based on your sensitivity report. Okay. Now let's go to treatment. Okay, so we started with herpes simplex. So we start first with the treatment of herpes simplex keratitis. Again, there is epithelial keratitis, there is stromal keratitis, and then there is the HSV keratouveitis. So we start first with epithelial keratitis. Again, showing you the branching pattern. In these cases, there's active infection. Okay, there is actual replication of herpes simplex virus on the surface of the eye, on these epithelial cells. Okay, because they will follow the nerve and they will infect the epithelial cell. Okay, then will infect the next cell, and then they progress. Okay, so this is there's active replication of the virus. So all the time, a must. At the very minimum, you have to give topical acyclovir or topical ganciclovir. Okay, that's it. That's the only thing that you should give. Okay, do not give antibiotic. Don't have to give. If the patient cannot buy anything else, just make sure you give acyclovir or ganciclovir. Okay, don't need atropine. Don't have to go over prophylactic antibiotics if they cannot be able to afford. Okay, so dosage 4 to 5 times per day. Okay, 4 to 5 times per day, and taper once epithelium is healed. Once you don't see staining anymore, then you start to taper. Okay, do not put them on prolonged acyclovir and ganciclovir because they can become toxic. Okay, so usually the course is around 1 to 2 weeks, and that's it. Now, if you have to give them steroids, normally if the periphery, don't let it just form a scar. That's fine. But if it's over at the visual axis, you're afraid you might form a dense scar, you can give a very mild topical steroid, but you do not stop your antiviral. You overlap it. If it's 4 times a day antiviral, you also give 4 times a day steroids and then slowly taper them off, okay, until the eye is nice and quiet. There's no need to give for oral acyclovir for one episode, okay, or the first episode of HSV epithelial keratitis. Okay. Now, another present manifestation is your stromal keratitis. So kasama na dito yung non-necrotizing, necrotizing, and then endotheliitis. Okay, so they give you this edema of the corneal stroma. Okay, and then if it has been there for more than 2 weeks, you will start to have vessels growing into it. No, that's a very important clue. Okay, so every little thing, every little sign is a clue. And you see vessels, 2 weeks na yan. Okay, in the first 2 weeks, you will not see blood vessels growing into the stroma. You stain them, the overlying cornea is intact, epithelium is intact. You do not see staining, maybe you see just microcystic edema, and that's it. Okay, so this is a non-necrotizing type. Okay, a very rare form is a necrotizing type. No? Okay, this is partially treated. Okay, so but you can still see the area that has necrosis or at the center. The periphery has started to heal. Okay, see, and then the vessels are here now again because it is more than 2 weeks. Okay. Now this endotheliitis. Now, how this differentiates stromal from endotheliitis? You look for the KPs. Okay, so this is diffuse, and this will be the disciform. Okay, diffuse endotheliitis lahat white to white. Then you have a disciform. Okay, just that area, that around coin shape lesion at the center. There's edema. Okay, and then you see keratic precipitates now on the endothelium behind the area, the affected area. Then you call that your herpes simplex virus endotheliitis. Okay. Okay. But if you can tell, sometimes the edema is so thick, you couldn't see the KPs. That's no problem because the treatment is exactly the same. Okay, so don't forget, you still have to give your topical antiviral, but you have to give steroids here. No? So that's first, you have to give steroids here. No? That's the most important, okay, together with topical acyclovir or ganciclovir. And at the minimum 4 times. Now, usually I will start with 6 times a day, 6 times a day, taper weekly over a month, or till keratitis clear. No? It takes a while, okay? So 6 times a day, then taper weekly over a month. And again, taper accordingly. No? If you're tapering off your steroid, you taper off the antiviral or the same frequency. Oral acyclovir has no benefit. So if the endostromal keratitis and endotheliitis, you don't have to give oral unless they have more than 2. So 3, more than 2. So 3 recurrences per year, then you can put them on acyclovir 400 milligrams twice a day, okay, as prophylaxis, as long as they can afford it, as long as they can tolerate it. Or if it's the only eye, no, then maybe you want to give it earlier, okay? Now, sometimes you see this kind of pictures, magulo, okay? May ulcer, okay? Pseudomonas ba yan? Strep ba yan? Okay, fungal ba yan? May hypopyon pa, nako, baka may end-off na. Of course not. So, check again, observe at the eye. Look at the patient. If the eye is wide open, okay, they are not in severe pain, okay, but you see this lesion that looks really bad, then you think of herpes simplex keratouveitis. Okay, that's an important clue. Okay, if it's fungal, if it's pseudomonas, if it's strep, okay, masakit, no, masakit yon. But anytime it's herpes simplex, there's not much pain. No? So despite the severe appearance on their slit lamp on the cornea, okay, they will not come into you with a very, very painful eye. Okay, so you see these lesions and hypopyon, KPs, you know, magulo atsura. Okay, then you think of HSV keratouveitis, especially if there is hyposthesia. Okay, this is one of those again. You know, we look at it, gulo, no? Okay, makula, or there's severe edema, and then there is panus formation. There is breakdown epithelium. When you look at the efflorescence, okay, you have disorder. Is it geographic or not? I'm not sure. Okay, hindi naman siya bukang dendritic. Okay, but if you check the corneal sensation, it's almost absent. Of course, there's also hypopyon there. Okay, then You ask the history, previous attack, blah, blah, blah. Okay, herpes simplex, yan. Okay. So you're dealing with that, okay, steroid pa rin, no? Because this is, again, mostly an immune-mediated, no? So topical steroids, you also give topical acyclovir or ganciclovir, and your atropine, okay, because there's already a uveitis. 6 times a day, taper slowly once resolving, okay, and you may give, no, the head studies show that you may give for this case 5 times a day, okay? Maintenance is twice a day, active treatment is 400 milligrams 5 times a day. You may give for this case, especially if they are immunosuppressed, then you should. And sometimes very hard to withdraw them, no? Once you stop, they recur. Okay, so I have cases we've been treating for years and years and years, no? So the books doesn't tell you how to taper meds. The books that will not tell you how to how long you should put them on. You just play it by ear. You just tailor everything to the needs of the patient. Okay, you follow them up. You find the minimum, okay, the minimum amount of medication that will keep them disease free. Again, you cannot eradicate, because you cannot eradicate herpes simplex from the system. There will always be cold latency into the trigeminal nerve. No? So they will always find a way to wake up and cause a problem. No? So we have to keep medications on and on. Okay, so that's where the again, it's a case-to-case basis now. What should you should know the principles. Now, there is such thing as a metaherpetic. It's easier to understand if you say a neurotrophic ulcer. No? This is no longer active. There's no uveitis. It's just a poorly healing corneal epithelial defect because there is no nerve stimulation. No? So you know that you need neural stimulation for the surface epithelium to heal. No? So, or it can just be pure and simple drug toxicity. No? That's another reason for your metaherpetic ulcer. No? Alam nyo, so there's still a defect, they follow up, you put on acyclovir, oops, hindi pa gumagaling, may defect pa rin, sige pa lang, tuloy-tuloy, okay, 1 month na, naka 5 times a day pa rin, and you still have this non-healing defect. Now, if you have that, that's most probably toxicity, no? Because if it's active epithelial, no, give it a week of acyclovir or ganciclovir, no, nag-heal na yan. No? So kung 1 month ka na, toxicity na yan. No? So all you have to do is just stop your antiviral, okay, debris, okay, remove sometimes just because of the necrotic tissue here that has accumulated because it is now excavated. You have to debris it with your blade 15. You remove the necrotic tissue, freshen up the edge of the border because usually they're rolled up like this, okay, and they will heal. So here, how do you do? It's a toxic effect. No? Stop your antiviral, give them non-preserved lubricants, debridement of the edges and the base. You can put bandage contact lens. Okay, very rarely now we do tarsorraphy because bandage contact lenses are now so cheap. Okay, and they are highly oxygen permeable. So they do work very well. No? So your bandage contact lenses in this for this slowly or non-healing epithelial defects. Okay, so these are just another. This is a sequelae. No? So if you do not treat your stromal keratitis well, the blood vessels will go in after 2 weeks. Okay, and then they will heal. But however, the vessels will start to leak, and you form this opposite lipid keratopathy. Okay, and like here also a lipid keratopathy because of the active vessels here, okay, that you're not able to control. No? So patient also end up with corneal blindness. Okay, so these are that's herpes simplex. Okay, now for bacterial keratitis, okay, topical, no, is still the mainstay. Okay, kung isa lang ang pwedeng bilhin ng pasyente, it should be topical, not topical. Should be topical antibiotics. Okay, no need for oral. Okay, you do not have to give them coamoxiclav or whatever. Okay, just give topical. So, which should you prescribe initially? Of course, if you always start with a broad spectrum, okay, given every 15 minutes for every 1 to 2 hours is a loading dose, and every 1 to 2 hours after that. So nowadays, no, we always choose 4th gen fluoroquinolones. Okay, Very rarely now we give a combination or fortified antibiotic because multiple studies have shown the fourth generation fluoroquinol or the newer generation fluoroquinol are as good, okay, or even better than the other previous other classes of antibiotic drops. Okay, so you have to know your fluoroquinolones. Okay, so these are the older ones, these are the newer ones. No, so the older ones like Cipro, it's more for gram negative. Okay, but the Levo, the Moxie, and Gatti, they're more now for gram positive. Of course, they have effect on your gram negative, but more on the gram positive. Okay, because before we really had not much option no, for the treatment of gram positive organisms. But nowadays, you take staph and strep, no, okay, with the newer generation fluoroquinolone. Okay, so if your bacterial keratitis is improving with your empirical therapy, okay, then just continue, no, and taper very gradually, okay. But if it's not improving, what do you mean by not improving? Okay, lumalaki, okay, palaki ng palaki, panipis ng panipis yung cornea, that is not improving. Okay, but if this today is, if you saw the patient you saw the patient today, saw the patient again after, you see the patient after a week, and they're exactly the same, that is a finding. That is no change. If there's no change, that's good. Okay, no change is always better than advancing. Okay, always remember that. No? Do not feel like no change, wala nangyayari. Kaya nga may nangyari, kaya nga no change eh. Kasi kung wala nangyari, lumaki na yan, nag-advance na yan, nag-melt na yan. Okay? So maybe you just have to, maybe you're underdosing, maybe kulang, no, or there's toxicity. So madami ibang reasons. But again, no change is better than advancing or progressing. Okay? It should be progressing. Okay? So always check, no, compliance is very important. It's very difficult, no? It's hard to give medications every 15 minutes, no? So it's every hour pa, or maybe the first day it's fine, but the second day, okay, they won't do it much. By the third day, no, kulang-kulang na yan, okay? So, or then that's why you also need your culture sensitivity, because you have to look at it and might be dealing with resistance. Very real, very problem, no? We have a problem, no, with resistance, no? So it's wiser to do culture and have some specimens sent for culture and sensitivity. Okay. It used to be, no, that they say that fortified antibiotics give a higher therapeutic antibiotics, but again, it's no longer true. Okay, but if you really want, there's still the initial options of cefazolin and tobramycin. Then the alternative therapy is vancomycin and or ceftazidime. Okay, so but it takes it's hassle to make this, so usually you don't give unless you're dealing the organism is resistant to all the available, commercially available newer generation fluoroquinolone. Don't forget to give your atropine. Okay, in some cases, if compliance is a problem, you might want to give some conjunctival antibiotics, no, as a depot. At least there's something rather than they can't put in the drops. Okay, always monitor the size of defect. That's why you all need a baseline. No, you need a baseline. After if you don't scrape, at least what you have on baseline. If you scrape, you then measure again, no, and that's your baseline. No, and you use that to monitor if the defect is healing or not. The very first thing that would heal will always be the epithelium. Okay, that's the first thing that will grow smaller. Okay, the hypopyon will take a while. Do not expect the hypopyon to go away. Okay, as fast as the healing of the epithelial defect. Okay, sometimes you have to wait for the epithelium to totally close before the hypopyon will go away. Okay, as long as it's not increasing again in height, that's fine. The redness, kung may hypopyon pa yan, may redness pa yan. No? So next, pag nawala na yung nag-heal na surface, nawala na yung hypopyon, tsaka lang mawawala yung redness. Okay, do not expect everything to disappear at the same time. Now, steroids. Okay, I do not give steroids while it's active. I only give steroids once the epithelium is healed. Okay, but I do not stop the antibiotic. Okay. Now, if the cornea perforates, which is we see a lot of this at PGH. Okay, if there's a blind eye, then it's conservative treatment, or you can want to put a tissue glue if the perforation is small. If there's no cornea available, they can do a flap, especially if the perforation is the periphery, just like in gonococcal. Or if your cornea is available, then you do a patch graft, a lamellar graft, or a PKP, because penetrating a keratoplasty is at the same time therapeutic. It's not only for tectonic reason. A lot of times it's also therapeutic. You remove all this, the organism. Sometimes it's not the organism. Sometimes it's sterile na yan eh. It's just there's too much necrotic tissue, so much cytokine, so much inflammatory cells there, okay, that the eye refuses to heal. No? So it's the healing now that is, it's the immune response, and that's causing the problem. So you just have to remove those from the eye by doing a therapeutic keratoplasty. Okay. Now for fungal, hindi naman end of the road, no? So fungal, a lot of times, actually there are a lot of fungals out there that heal on its own, okay? So because the superficial lang, there's a tears there, it washes it away, and or their own immune response, okay, will eradicate the fungus from the surface of the eye, okay? The main problems are those given steroids. Those are the ones that will really make the fungus, the fungi go into a moderate to advanced state by giving steroids. Okay, so please, when you are not sure, please do not give steroids, because it's like adding fuel to the fire. You give steroids in cases of fungal keratitis. Now, if the ulcer is small, it's less than 5 millimeter, okay, usually topical antifungal will work. Sometimes hindi pa nga, sometimes debridement alone, it will work. Okay, so basta maliit. Okay, so like this one, it's a small, so less than 5 millimeters, okay, indistinct border, all the hallmarks of fungal keratitis. You see the feathery border, you see a plaque, then it grew, fusarium, okay, here you just debris, okay, gumaling na. Taran, okay, so you can treat this, you can resolve a fungal keratitis if it's superficial, okay? Ang problema kasi, kung naging stromal, because your antifungal agent will not penetrate, okay, into the they are large molecules, no, they're very, very poor tissue absorption, no? So wala kang therapeutic level of the fungus, of the antifungal agent in the stroma, so you do not want them to go into the stroma. So we do frequent keratectomy, okay, that will allow, that's at the same time decreasing the load, and sometimes that will help with the penetration of the antifungal agent. Natamycin, anything, it's always natamycin. Always think of natamycin. Okay, good for fusarium, good for aspergillus. Okay, good also for candida. No, so natamycin, well, amphotericin is better for candida, but again, natamycin will also work. No, so natamycin, 5%, is always your first line. Okay. So others options will be amphotericin B, hardly done anymore because it's toxic. It's hard to keep, okay, and they become very unstable. And voriconazole is another second choice. Now, from natamycin or your voriconazole. Now, usually you just choose between these two. Okay, very often 1 drop every 15 minutes round the clock at the start. Okay, again, because why there is no tissue penetration, no, they don't form a depot. It's really by contact, no? So that's why you have to put it very often. It acts on contact to the fungus, no? So you want to flood the ocular surface with the antifungal agent. In severe cases, as there's perforation, you might want to give oral antifungal. Yeah, but again, avoid steroids at all costs. Okay, no matter what, do not give steroids if you are dealing with the fungal keratitis. Now, if it's very moderate to severe, usually it's impossible to treat with topical. No, you really should prepare the patient now for surgery. So you try pa rin, sterilize as much as you can, but prepare. You know, you have to do now a therapeutic graft. Okay, this is aspergillus, very severe. Okay, almost close now to the periphery. Okay, it perforated. Okay, it melt down because of the cytokine. No, okay, it will cause the cornea to necrose, and then goodbye cornea. Okay, actually this is almost sterile. Then you do a graft. Okay, like so. Okay, but that's at the end of the story. Even you after a graph, okay, recurrence can occur. That's why you do not give, you continue antifungal at least for the next 1, 2, or 3 months post PK. You do not start steroids for the next 2 weeks after PK, no? Because if you give steroids, this occurrence can occur. Okay, but after 2 weeks, kung wala off steroids, still antifungal but no signs of recurrence, then that's the only time you start giving your your steroid drops, no? Okay, so this is a recurrence, but sometimes you end up with this. Okay, so again, a total of the entire cornea has been eaten up now by the fungi. So that's the end of the line for this eye. Okay, acanthamoeba, pain out of proportion of corneal findings, then that will be signed. Ring infiltrate, those will be your important clues. Okay, don't look for perineuritis now because you will not see them. They're not very common and they do not respond. Hindi na gumaling sa antiviral, hindi na gumaling sa bacteria, antibiotic. Maybe it's acanthamoeba. Okay? So you look for the cyst. This is from the scraping. This is from in the tissue. For the cyst. So the aim of therapy is both the therapy should be trophocidal and cystocidal. That's why we give combination. Okay? Because a trophozoid is easy to kill. Now, it's a cyst that they hard to kill. The problem is if you have trophozoid and you give your amoeba drops, no, then they will, because they're not in a toxic environment, they form into cysts, no, and then they are very resistant, okay, to the drugs. Okay? So that's why treatment should include, I should have PHMB or your chlorhexidine. No, it's harder to make PHMB. Chlorhexidine is more available. Okay, or you have your propamidine. Usually, at the very minimum, propamidine and your chlorhexidine. Okay, and you have to follow a treatment for at least 6 months. You do not stop anti-amoeba drops, okay, for at least 6 months, or else it will recur because of the cysts. You don't know where the cysts are. Okay, you only need one cyst to become to activate and then to replicate, and then you're back to square one. So this is Brolin. You have the drops form, and then you have your ointment form. Okay, this is a over-the-counter medications. No, very very old. Okay, this is like your, parang ayaw mo to in the Commonwealth, in the British region, in the Commonwealth. Meron yan, no? Easy to get that. Okay, this is your PHM. It's a pool cleaner. Okay, so you can use that and formulate it to 0.02%. Okay, mahirap, no? Ilang dilution yan. Okay, or your chlorhexidine. Okay, so PKP is not a cure. Okay, this is a patient who had 5 PKs, 5. Okay, due to acanthamoeba. But the previous surgeon kept on doing a PK, it kept on recurring, then did the PK again, and it recurred. Okay, 5. Okay, of course, nag-recur. So patient transferred. Okay, then of course, repeat. We treated the patient with anti-amoebic drops because with the 5 PKs, there was no anti-amoebic drops. No. So see, you still have cysts. Okay, maski na necrotic na yung cornea, may cysts pa rin. Okay, so always remember, put anti-amoeba. Once quiet, then if it perforates, then you can do a PK. If you're on PK, tuloy pa rin, no, for 6 months. Do not stop. Okay. Dr. Balenton had advocated the use of supportive therapy. Ito kasi it's hard. It's hard to get PHMB or chlorhexidine, okay, topical, no. So sometimes you just let the patient's own immune system take over. Okay, so this is an example of a patient. Okay, this is during the first visit. Now, 1 month later, okay, mukhang nag-worsen. Okay, looks worsen. There's a large defect, infiltrating the through. Okay, no anti-amoebic medicine pa rin. By the 2 months later, looks like it's better. It's improving. The defect is smaller. By 3 months, surely, by this time, we can actually say patient is healing. Okay, the defect is much smaller. Okay, this has scarred the periphery. By the 5th month, lumipalalo, scarred na yung gilid. Still, no anti-amoebic drops. Okay, by 1 year, patients will end up with this central scar. Okay, so not only this is not a fluke. We had 4, 5, or 6 patients treated this way. Okay, and they healed. So that's an option. Okay, now you can only do this when you don't have steroids. Okay, but maybe because this patient never had steroids, that's why this can happen. But in cases that were treated with steroids, just like your fungal keratitis, it will be a different story. Okay. All right. So that ends on the infectious keratitis. So we'll proceed to the other types of corneal lesions, flectinulosis versus marginal ulcer. Okay. Next slide. So, flectens, okay. Flectens versus marginal ulcer. These are nodules. Now, flectens are nodules usually located at the limbus, but they may occur at the cornea and conjunctiva, while marginal ulcer are infiltrates or ulcers at the peripheral cornea. There's no clear zone between the lesion and the limbus because they straddle the limbus. While marginal ulcers, there's a clear zone between the lesion and the limbus. Here, vascularization is very prominent. Here, usually absent at the start, okay? But later on, they can form. But at the start, kasi flectens start lang. Ang dami ng vessels. Ito halos wala. Now, this is T-cell hypersensitivity reaction, type 4. This is an antigen-antibody reaction. There's a difference between the two. Okay, so to put the picture side by side, this is a flecten. See that? It's a nodule, okay, that hasn't ruptured. It straddles the limbus. And these are marginal ulcers, usually inferior because they're highly related to staph, okay, and there's a clear zone, okay? These are immune-mediated. Etiologies, flectens, number 1 pa rin tuberculosis, due to staph, Haemophilus, etc. Marginal ulcer, staph ang number 1. Basta most common, flecten in the Philippines, TB. Marginal ulcer, most common, staph. Okay, then you have the rest, Haemophilus, Rep, Moraxella, but staph pa rin ang pinaka-common. Okay. TB flecten, okay, so we call this a wandering flecten because a corneal flecten. Of course, it started at the periphery, it's just that it wasn't treated, okay, then it proceeded to the center, okay. Just today, I just saw another patient, very long time, usually I hardly see any flecten in private practice, but here's a private patient, okay, seen in March by another doc, I don't know, not an ophtha, but given fusidic acid only, okay, and because of the lockdown, was difficult to consult, and finally, the redness didn't go away, so after 5 months, so the patient had exactly almost, nasa 8 o'clock naman. Ito nasa 2 o'clock. Exactly the same, okay, flecten that has grown over the, has reached the pupillary area, okay? Usually kung ito, yung TB yan. Staph, okay? Usually inferior, okay, flectens, okay. These are large flectens due to Haemophilus. Now, patient has Haemophilus conjunctivitis. See those large flectens. Moraxella. Okay, patients see there's angular maceration here. Then now patient had here an ulcer, has a flectenulosis conjunctival. Now these are marginal infiltrates due to staph. Okay, pwede superiorly. Okay, here see that 1, 2, 3, 4. Multiple, usually multiple, yeah. Okay, so that's due to staph. Okay, this is marginal ulcer right there. Moraxella, pwede both, flecten and marginal ulcer. Again, look, macerated angle. Okay, so since flecten is due to TB, number 1, so do a X-ray, check for pulmonary TB, previous exposure. Okay. Treat underlying cause all the time, but since both conditions are actually self-limiting, but to minimize scarring and for early resolution, treatment is necessary. So usually we give combination antibiotic steroids, no, for the flectin. Now, for marginal ulcer, for me, I will usually go straight now to combination antibiotic steroid. But if you're not sure, you may start first with antibiotic, wait for the marginal ulcers to heal, then add steroids. But again, kailangan talaga ang steroids for both flectins and marginal ulcers or infiltrates because they're both inflammatory in origin. Okay, interstitial. Okay, so it must be diagnosed and treated early, not to prevent permanent corneal opacities in the form of lipid keratopathy. Okay, so the causes of IK, infectious, you have your syphilis, tuberculosis, leprosy, herpes. You've seen the herpes simplex. Tuberculosis, we have a lot of that. Syphilis, not so much now. Of course, not infectious, your Kogan syndrome. It was just presented as a case by recently. Sarcoidosis, lymphoma. Okay. Now, TB. Okay, these are. So in active, what is active? Namumula. Okay, dapat mapula. Pag walang redness, hindi siya active. So here you go. Okay, sometimes they have concomitant scleritis, but that is congestion. Okay, redness, they have scleritis, then it's not sclerokeratitis. You see peripheral corneal stromal edema, okay, with intact epithelium. No? There's no breakdown in the epithelium. Here's another one also. Okay, not as active as this, but there's some injection here. Okay, so you see this through stromal opacity. There is a vessel now, no? So 2 weeks na to. No? So my vessels na grow. Okay, so if we do not treat them, vessels will grow into the stroma and they will leak, they will lay down lipid, they develop now a severe lipid keratopathy, okay, causing permanent, causing corneal blindness. This is herpes zoster. This is herpes simplex, okay? So they cause because of the blood vessel. No? The problem is the blood vessel. This is syphilis, no? Showing you those vessels. Okay, this is old now. This is old lipid. These are just lipid that has laid down. You can form a ring type. No, this is syphilis IK. Sequelae na to, no? Hindi na to yung active. So when it's active, again, steroids still the mainstay. Look for the underlying cause. Okay, cycloplegic also. Sometimes you give triamcinolone injection, and you have a depot. Now you have to treat the vessel. There are many ways now. Used to be we do laser vascular. Now you can do cannulation. Now you can do burn them. Okay, but with very, very fine cautery, wet field cauteries. Okay, but to improve vision, now you can do the keratoplasty. If you can do a dock, the best is still to a dock. Okay, especially if it's not full thickness lipid keratopathy. Okay, in order to restore the vision. Okay, we're almost done. It's almost 9:30. Okay, so formers with the corneal opacities, no, it's not always fungal, no. So, but again, nowadays we don't see much of this anymore. I don't know if the practitioners out in the rice growing regions of the country, like Nueva Ecija, no, Pampanga, okay, if they still see paddy keratitis, no, because it's been a while, no, I haven't seen paddy at PGH for a long time. Okay, but the history, there's called Demers, numeral keratitis. Usually there's a history of mud splash from the rice field, no, and then most common blurring of vision is the most common complaint. Usually almost always multiple lesions, no, multiple lesions, no, to 10 to 10T at the anterior to full stromal thickness, no, the diameters are 1 to 2 millimeters, no. Okay, again, there is stromal edema but intact epithelium. Adjacent lesions may coalesce, okay, form a larger lesion or form an immune ring. Okay, so this is an example of paddy multiple nummular lesions. No, these two can coalesce, but you see these round lesions where there's a periphery even at the central part of the cornea. That's paddy keratitis. With this is dapat rice farmer. That should be it's the rice. You cannot just be any farmer. You have to grow rice. Okay, so here's another one that's coalesce. No, there are several lesions. Here there are 3 lesions side by side. No, it's paddy. Okay, more of that here. So this has healed. So they form a scar. Okay, at the center when it heals. So when they're not treated, there's a necrosis. The core will necrose and then form a dense scar. We try to look for the cause. No, we did with Rainier. We did the biopsy. Okay, from 4 cases, we tested for HSV and EBV because it can just do EBV daw ang nummular. Okay, negative by PCR. Okay, but that was a long time ago. We also did electron microscopy of these specimens. Again, it did not reveal anything abnormal. Okay, so I don't know. Exact etiology is still unknown. We tried. So the treatment, okay, so again, delayed treatment can lead to permanent corneal scars, so you treat them early. Steroids pa rin because it's immune-mediated. It might have an infectious etiology, but the steroid is still the mainstay. So then 4 to 6 times a day for 2 to 4 weeks, usually a month, no? Okay, you can even up to 8 weeks. In some cases, we give triamcinolone, okay, especially if they have more than 20 lesions, no? And para mas mabilis mag-resolve. Okay, sometimes it can recur on withdrawal of steroids. Okay, so again, if you see them, think about them. If they are not Jitopadi, your EBV, your Epstein-Barr virus will also present the same way, especially, but they will not have a history of mud splash. No, you see, maybe if you have a patient from the city, okay, walang history of a rice farm, and then nummular lesions, and they have a history of flu-like symptoms a few weeks back, and you have nummular lesion, think of Epstein-Barr virus, okay, because it can be due to that also, and they usually the clinical manifestation or the slit lamp examining findings are almost exactly the same. Okay, so that is the end of the corneal lecture. So that also ends the series. There are other things that we don't have to discuss, pterygium, hindi na kasi kailangan, and all of that. Okay, unless you want a part 4. Okay, that's it. Thank you.
Thank you very much, Dr. Lim Bonchong. And we now open the floor for questions. We have one question from Facebook, and this is from Dr. Cesar Perez. The question is, what are your recommendations if we request eye pictures from our patients with keratitis?
What do you mean? Ano?
Probably setting ng camera, I don't know.
Huh? Bright light, I mean, and clear. I mean, they don't have a macro lens. If they have a macro attachment, they're well and good. But of course, slit lamp photo is still the most ideal. Okay, but of course, the patient is at home. You know, they only have as far as good as their cell phones can do it. But at the very minimum, good lighting, and as close as possible, and as magnified as possible without sacrificing resolution. You can start from there.
Okay.
Kung walang makita, you really have to request for a face-to-face exam.
Yes. Okay. So, do you have any other questions?
Naka-assessors asking kung anong brand. Samsung ba? Samsung has a good camera. Oppo. iPhone na pinakapangit. Okay.
Oo nga, I agree. Okay, so Dr. Ray, Lisa,
no more questions?
Yeah, we're waiting for some questions. Ryan, do we have questions, YouTube?
Last 15 minutes for questions. Pa rin? Now? Saan? Okay. So, hindi na umaabot sa Manila. Nagtitreat na, ano. Still, really? In Apari? Bakit? Rice farmer bang Apari? Kala ko fisherman. Both.
Okay.
Okay, so madami pa rin. So, meron pa rin paddy outside Manila, outside the NCR.
So, we have a question from Dr. Myra Ocobilio. Can you comment on doing aspiration or washout of hypopion in patients with microbial keratitis?
Me in person, no. No, actually it doesn't do anything. So you aspirate today, tomorrow it's all back. No, so it's really just a waste of effort, and actually you might introduce pa the organism into the eye. There's really I don't see any benefit because it always will occur. As long as you do not eradicate the organism, removing it, unless you have uncontrolled glaucoma, you just want to relieve the eye of pressure, you can do it. But as a means to help resolve the infection, no, it will not.
Okay. Another question from Dr. Ricky Fontanilla. Good evening, sir. Is there still a role for using betadine drops for any of the infectious causes of keratitis?
Well, if you are pushed to the wall, okay, there's nothing else to give. You don't have anything to give. You can, but again, remember, it's a surface disinfectant. Betadine or povidone iodine works by contact. So it's contact time. Okay, it doesn't have tissue penetration. It doesn't have. It doesn't stay in tissue. So it can also be toxic to the epithelium if the concentration is too high. So again, it really, as a last resort, maybe yes, but if that's going to be your first line, no, because that's the main problem about povidone iodine. It can sterilize a lot of things, but it has almost no tissue penetration. Kung nasa loob na yung organism mo, kung nasa stroma na yung organism, it will not be killed.
Mm-hmm. Just a comment from Carlo Igama. Meron daw noong 2018 PADI in PGH. Anyway. Question from Dr. Noel Carino. How can you differentiate infectious peripheral ulcers from benign infiltrates?
Ano? How do you differentiate infectious peripheral ulcers?
Infectious peripheral ulcers
What is benign
from benign infiltrates?
Different infectious peripheral
ulcers.
Well, mostly peripheral. They're mostly per se. They are not infectious. The underlying mechanism, the etiology might be infectious, but the mechanism, the pathophysiology is immune mediated. So it's inflammatory. Okay. So kung nasa periphery nga, chances are they are inflammatory. Okay. I don't know what's the meaning of benign infiltrate. An infiltrate is always bad. So an infiltrate means there's a problem. Okay, so normally you should not have any infiltrate. Maybe he meant infectious infiltrate versus sterile infiltrate, not benign infiltrate. Okay, so yes, peripheral ulcers or peripheral lesions are usually sterile infiltrate, while central are infectious, unless it is gonococcal. Then it becomes truly infectious at the periphery.
How about, there's another question from Dr. Galvante. How about intrastromal injection of antibiotics or antifungal? Is there any role for that?
Yes, there is a role. Okay, if we're dealing with stromal abscesses, okay, let's say a typical mycobacteria, okay, then you can give stromal injections. If you have fungal, that is in the stroma, yes, you can inject even amphotericin and voriconazole. You cannot inject natamycin; it's too thick. Okay, it's voriconazole. You can inject voriconazole into AC. You can inject voriconazole into subconjunctiva. You can inject voriconazole into the corneal stroma. It's just like doing after clear cornea surgery, stromal hydration is exactly the same thing.
Yes.
You can inject levofloxacin, you can inject moxifloxacin into the corneal stroma, no problem. You can. Okay, that's another route of giving antibiotics or antifungal if the lesions are deep. Okay.
So do you use tuberculin syringe or
gauge
30?
Gauge 30, yes.
30, right?
Gauge 30. Okay. Here, Zan said, seen several padding. So, madami ng paddy. So, sana one of you please find out ano yung etiology. Okay.
Yes.
There is I mean, if there's a lot, there are a lot out there. I mean, if you can try to look for the etiology, because up to now, it's still a
It's still
blank.
unknown, yeah.
So if you want to be known, that's one of the few unknowns. No? You want to be known, okay, answer this unknown.
The answer the unknown.
Yeah.
So any other questions? So here from YouTube. Do you always give oral
No,
antifungal?
antifungal is not it's not a first, it's always just purely topical. Only if it becomes endophthalmitis, then you have to give. If it's a panophthalmitis, yes, you have to give. But if it's purely keratitis, no, I do not give, because there's no point. Okay, it will not reach the enough therapeutic level. No.
How about if it's
Serious.
associated with severe scleritis?
Alin?
Yung fungal.
If you have infection into the sclera, yes, okay, because you need blood vessels to bring the blood to bring the antifungal to the site.
Okay. Any other questions? Dr. Santos, Anna,
Okay na?
Dr. Yu, Dr. Ellen, any other questions?
No question, Jen, for me.
Wala na sa YouTube. Okay, no more FB questions.
No more FB questions.
Okay.
I think recipe ang gusto nila, Ruben.
I know. Follow me.
Meron ba? Or,
abangan lang sa post.
all right. If there are no more questions, may we request our president, Dr. Margarita Latluna, to give the closing remarks. Marcia, unmute.
Okay, good evening. On behalf of the Philippine Academy of Ophthalmology, I'd like to thank and congratulate Dr. Ruben Limbonsiong for another stellar presentation. The PAO members have certainly benefited from this relevant and useful information and his experiences that he has shared with all of us. It brought back my memories of my fungal keratitis. Likewise, kudos to the Philippine Cornea Society for organizing this series of lectures. Congratulations. We also thank our sponsor, Santen, for their continued support, and of course our tech team. Thank you for our tech team has actually been very generous with their with sharing their expertise with the other subspecialty societies, so that they can also conduct their own live streaming. So we hope to see you once again in our upcoming webinars. Thank you and good night.
May we now also call on Jenny Ramirez from Santen, our sponsor.
Okay, so good evening. I hope you can hear me.
Yes, we can.
Okay, so a pleasant evening to all the ophthalmologists who have joined the last of three-part lecture initiated by PAO and of course hosted by PCS. I'd like to thank the Academy and the PCS officers and members for the opportunity to partner with you for this lecture series. Thank you for your trust in Santen. And of course, to our esteemed speaker, Dr. Ruben, thank you very much for continuously providing the Academy and its members, and of course, us industry partners alike, an educational topic that is both very practical and enlightening. So your lecture has always brought valuable insights from your current practice, especially during these relevant times. So to all the ophthalmologists who watched this webinar, I'm sure you were able to learn a lot from Dr. Ruben. Rest assured, Santen will remain to partner with the Academy for more stimulating topics in the next webinar, if only to support your continuing medical development. And lastly, and of course, this is a bit off topic, to help minimize the risk of the coronavirus infection of both you, dear doctors, and your patients, with the indulgence, of course, and the help of PAO and the Secretariat. Santen will be giving breath shields to all the PAO members. So we hope this device will further protect you in your practice and, of course, deliver everyday happiness through clear vision. Okay, so thank you for spending your precious time tonight, and good night.
And of course, to cap the evening, may I call on again the President of the Philippine Cornea Society, Dr. Reynaldo Santos.
Well, I can't thank Ruben enough, our immediate past president, for his indulgence really to accommodate a request for this marathon lecture, for 3-part series. He tackled everything from the lids to the conjunctiva to the cornea. And I think a good number of our residents who are listening have learned a lot on this so that they're able to clinically recognize disease and do some quick evaluation of what they think patients might have, especially in this age of teleophthalmology. So again, Ruben, thank you for accommodating the request of the PCS for you to deliver this. Thank you too for Santen Philippines for their continued support for the advocacies and endeavors of the PCS. Of course, I'd like to thank also the PAO for giving us the opportunity to be able to participate in this distance learning programs that you have. I think, Jen, this month will be the last of a series because you want to by November or October, no more long distance programs. Am I right?
Yes, sir. Just the lifelong educational program or the LEAP
program. So watch out for our LEAP programs. We have partnered with the Western Visayas Society of Ophthalmology.
Yes, sir.
And we'll be featuring younger ophthalmologists there, si Myra Ocubilio.
Younger than you.
Young. You're the oldest.
So we look forward to Myra and Nor Iguban for that LEAP program. Again, thank you again to everyone. Thank you.
Thank you. Thank you. Don't forget to sign the attendance.
Okay. Bye-bye.
Thank you. Good night.
Good night.
Thank you to our tech teams. Good night.
Good night. Bye-bye.
Night.